Hi there, this is Nizul. This lecture is going to be on anemia, particularly looking at iron deficiency anemia and sickle cell anemia. There are many types of anemia out there, so you have hemolytic anemia, pernicious anemia, or vitamin B12 anemia, but for this particular lecture, we're mostly focusing on iron deficiency anemia and sickle cell anemia. We'll be going through the etiology or the cause of the different types of anemia. We would also look at clinical manifestations or symptoms that the patient will have, and to a lesser extent, the diagnostics. For sickle cell anemia, however, we will look at treatments, or we'll talk about the treatments of sickle cell anemia. Before we go into the actual anemia, though, I think it is critical that you understand the life cycle of a red blood cell from the time it's produced, and once that red blood cell is broken down, or what we said hemolysis, which is a normal process in the life cycle of a red blood cell. What are the byproducts and what is required for the production of new red blood cells by a process called hematopoiesis. So we're going to look at the life cycle of a red blood cell. And so pretty much what we're looking at is the process of erythropoiesis, which is the production of red blood cells from the bone marrow. So it starts out in the bone marrow. And so something is triggering this process to occur. And usually what triggers erythropoiesis to occur is a decrease in circulating O2 in the blood, or decrease in circulating oxygen, which then sends the signal that we need more red blood cells, so we need more oxygen carrying capacity in the blood. What is also involved in this process is EPO, or erythropoietin, that comes from the kidney. And once EPO comes into that picture, the red blood cell is now going to be made from the bone marrow. Red blood cells are in the shape of a donut appearance. So these red blood cells are now going to be made to try to increase the oxygen carrying capacity of the blood. Red blood cell has a lifespan of 120 days, after which it's a normal process for them to die off, or what they end up going through is hemolysis, where the red blood cell gets split. Once the red blood cell undergo hemolysis, hemoglobin is going to be released. And so that is really the makeup, or the structural makeup, of every red blood cell is hemoglobin. Once hemoglobin is released, that hemoglobin gets split into heme, which is the iron component really of red blood cell, and it also gets split into globin. Globin is the amino acid portion, so that also is going to go off to be recycled. So we don't really get rid of any of this stuff. So the globin is going to go back into circulation, or that protein component is going to go back into circulation, and that's where it's going to be recycled. You still have your heme, and so what's going to happen to this heme now? Heme is going to be split into iron and bilirubin. And so we won't really touch too much about the bilirubin here. Once we get to the liver content, you'll see more about bilirubin. So what we have here now is iron. And this iron is actually, if you're needing it at the time to pretty much go and make more red blood cells, then it's going to get involved back in that process where it's going to be recycled, and it's going to be used in the production of red blood cell synthesis. Also, remember, we're able to store, right? And so iron can also go into the liver, where it's going to be stored inside of the liver, and that's where we're going to store it as ferritin, or if you look at your notes, there's also something called hemosiderin. So ferritin and hemosiderin are iron stores in the body. So if we are having to need additional iron for red blood cell synthesis, we're going to tap into that liver source. One additional thing that's also, so we also need folic acid, but something else that we also need that for red blood cell synthesis, but we don't really cover it or we don't really focus on it, is vitamin B12. And vitamin B12 really does come from the foods that we consume, but I don't want you guys to lose track of that. Once we consume vitamin B12, vitamin B12 also plays an important role in the process of RBC production. However, like I said, we don't really focus on this part of vitamin B12. Deficiency of vitamin B12 that will affect RBC synthesis results in pernicious anemia. So really for this class, our focus is looking at depletion of iron stores, which is ferritin or hemosiderin, and how iron plays an important role in RBC production or in the process of erythropoiesis. So when we look at anemias, anemia means that there is a reduction in erythrocytes, which is the other name for red blood cell. In other words, it's a reduction in the oxygen transport or the oxygen carrying capacity of the blood. And basic problem, obviously, is a hemoglobin deficit or an erythrocyte deficit. So something is happening. And as we've established, there's many things that's needed for RBC production. So we need the hormone EPO, which is coming from the kidney. We need iron, we need folic acid, we need vitamin B12, and those are just some of the things that we need to make a red blood cell. We need an intact bone marrow with the capability of undergoing erythropoiesis. So obviously there's a number of things that's required in RBC production, and we already established that red blood cell would normally undergo hemolysis after 120 days. That's a normal life cycle for a red blood cell. So if you think of some of the things that oxygen deficit can lead to, what might be some things that if we don't have enough oxygen or if we have a reduction in oxygen transport in the blood, what might be some of the things or how might that affect you? Obviously, we require oxygen. We are aerobic human beings, like human beings are aerobic. We need oxygen for metabolic processes and for metabolism in the cells. When we talk about shock, for example, if you look back at that, we said if you don't have oxygen, the body will undergo anaerobic metabolism with a byproduct of lactic acid. So you obviously know that less oxygen will mean that energy production or ATP production in the cell is going to be reduced. Cell reproduction also is going to start to be diminished because they don't have that oxygen supply. We have cells, or epithelial cells. They're a living tissue. They will die off after a certain time. And so in order for those cells to regenerate, again, they need nutrients and oxygen in order to make new tissue. So if you think about that for a second, things that will become affected, you would end up having the digestive tract will start to become inflamed and ulcers will start to develop, leading to stomatitis. So stomatitis is, I know people tend to think of stomach, stomo, but actually stomatitis is in the mouth. So you're going to start to have ulceration in the mouth. Inflamed and cracked lips, dysphagia, hair and skin may start to show degenerative changes. So when you look back with oxygen deficit, these are some of the things that we're starting to see: less energy production, reducing cell metabolism and reproduction. When epithelial cells starts to die off, we're going to start to see decreased regeneration. And so particular areas that are going to be affected is the GI tract, the mouth, where you're going to end up with ulceration or stomatitis, inflamed and cracked lips, dysphagia, hair and skin may also start to show degenerative changes. Signs and symptoms that you could see, and remember this is just generally talking about anemia. This is not really just focusing in on iron deficiency, but this is applicable to iron deficiency anemia. Severe anemia will lead to angina or heart failure. So if you think about that and you ask yourself, but why? With severe anemia, it means that the myocardial oxygen demand will be decreased, when you have increase in myocardial oxygen demand, if you have a decreased oxygen carrying capacity in the blood, then the myocardium is not receiving enough oxygen. So remember, angina equals chest pain. So if I increase my myocardial demand, but I'm not getting the oxygen that is required, as you would imagine, I would start to have discomfort, or I will feel chest pain. What would start to, so one of the compensatory, when we don't have enough oxygen, the body thinks the only way to compensate is sort of increasing heart rate. And ultimately that's going to increase the myocardial workload again, and eventually can push the patient into heart failure. General signs of anemia: fatigue, pallor, shortness of breath or dyspnea, and tachycardia. So if you ask yourself, why are these occurring? So why is my patient feeling fatigued? So if you think about the importance of oxygen in the body, one of the reasons why is oxygen is not available for metabolic processes, right? And we just established we are aerobic human beings. We need oxygen for metabolic processes, and if we don't get that oxygen, it means that there's going to be decrease in ATP or energy production. Why does your patient appear pale when they are anemic or when they have decreased red blood cell? Now, red blood cell has colors, obviously. So with decrease in red blood cell, you have less circulation to the peripheral areas, so the patient will start to appear pale, right? So if you look at their lips, if you look at their sclera, sometimes of the eyes, so with darker skin tone patients, you would want to look at the sclera. It could be very difficult to see that they actually look pale when you're documenting or when you're doing your assessment. But also think about the compensation. So if my oxygen level goes down and my body is sensing a decrease in oxygen carrying capacity, you might have activation of SNS as a compensatory mechanism. And if you remember since we've been talking about SNS will cause catecholamines to be released, which will cause vasoconstriction of peripheral blood vessels in an attempt to shunt that blood back to the key important areas. By doing that, the patient appears pale. Shortness of breath or dyspnea, obviously, if you have decreased oxygen, the body thinks that it has to stimulate and or increase the respiratory rate to compensate for that decrease in oxygen carrying capacity. It doesn't recognize that it is not a respiratory problem. It really is you don't have enough red blood cell. So this is why you're short of breath, right? Most patients, once they are anemic, it is absolutely, it's a no-brainer that you most times, more often than not, will find the patient to be tachycardic. And why is your patient tachycardic? Again, is looking at that SNS compensation. So once catecholamines are released, they're not only going to attach to alpha-1 receptors in the blood vessels, causing vasoconstriction, but they're also going to attach to beta-1 receptors in the heart, where they're going to increase the heart rate. So tachycardia, pallor, dyspnea, some of those things are seen as an effect of your compensatory mechanism that is activated, which is the sympathetic nervous system that is being activated. So because of the first initial diagram that we drew, we saw that iron plays a significant, or it is a significant component of hemoglobin. So remember, when hemoglobin gets split after hemolysis, hemoglobin becomes heme and globin. Globin was the protein component and heme is the iron component. So if we don't have enough iron, obviously it's impairing the hemoglobin synthesis or the production of the hemoglobin molecule. Because it's impairing the structural component, which is hemoglobin, red blood cells that are from iron deficiency anemia are often microcytic and they are hypochromic. So microcytic means that they are small, so they're smaller than your normal red blood cell. Hypochromic means that they are less red, so they don't appear as red as the normal red blood cell. And like I said, it's sort of repeating that because of the iron deficiency, you're going to have low hemoglobin concentration in the cells. Iron deficiency anemia is very common. And so you're going to expect it to find a lot of your patients having it. It's not very uncommon at all. It can range from not so severe, where it's very mild in your everyday population, or it could be very severe, where we would have to do blood transfusion, etc. for those patients. Patients across all age groups are exposed to iron deficiency anemia, but it's very much more common in women of childbearing age. And so if you ask yourself, why would you expect it to be more common in women, you start to think that women of childbearing age are still having their menses. And so if you think about the amount of blood loss that happens every 28 days, so a woman with a normal menstrual cycle, usually every 28 days, they're losing with having their menses, how that might affect iron stores. So you want to think about that, right? Bleeding, if I'm bleeding often, I may not be able to have that iron reserve in my liver, right? Because I'm losing blood very often. Or if someone with chronic blood loss, for example, and we'll get to that topic in a minute. But if you think about women, why are they more susceptible when they're having their menstrual cycle? Is that the women are bleeding every 28 days. They're losing their iron reserves. So you would expect that their ferritin level and their hemosiderin level, which is the iron stores, are going to be depleted. And if those iron stores are depleted, they're not available for synthesis of new red blood cells. Estimated that 1 in 5 women is affected, and obviously the proportion greatly increases for pregnant women because they're providing the child with iron as well for their own synthesis. Usually if patients come in with iron deficiency anemia also, sometimes it's an indication that there's an underlying problem. So there could be something else that's going on. Sometimes it could be neoplasms that we're starting to think about, or cancer, if patients are coming with unexplained iron deficiency anemia. So they don't have any active bleeding. With your patients with their menses, or let's say someone is having chronic GI bleed where they're having rectal bleeding, or they're always bleeding from their hemorrhoids, for example, there's an explanation for that iron deficiency anemia. But often when we have no explanation, then we start to look for the more worrisome stuff, like neoplasms or cancer often. Just on the next diagram, or the next slide, sorry, I just sort of put up so that you can have a visual of what red blood cells look like in patients with iron deficiency anemia. So it gives you a bit of what our normal red blood cell looks like. So all these nice red ones at the bottom that you could see, whereas the other ones are at the bottom, and I know it's kind of cut out at the bottom, but these are your lighter guys here are the microcytic hypochromic. Okay, so microcytic, if you look them in comparison to the other red blood cell, they're very small compared to the normal red blood cell. They're less red, so they're hypochromic. So these, when they do the blood smear, once the lab has picked up that they're picking up microcytic hypochromic red blood cells, then they know obviously the patient has iron deficiency anemia, and then often what the next step is to try to investigate the cause of that iron deficiency anemia. So looking at the etiology and or risk factors or cause for iron deficiency anemia, the number one cause is poor iron intake. So generally, patients are subjected to iron deficiency anemia because of poor or minimum iron intake that what they're required. Most people enjoy meat and all that stuff, but if you think about foods that are rich in iron, are your thick green leafy vegetables. So this is the number one cause. There are other causes for iron deficiency anemia, like we mentioned before, your women that are of childbearing age because of their menses. So any kind of chronic blood loss. So any bleeding, if you have ulcers and you're bleeding for those ulcers from your stomach, hemorrhoids, like I mentioned before, in patients that are cancer patient, where once we get to week 13, well, to week 12 this semester, and we look at the chronic blood loss that's associated with cancer because of the tumor cells are using up blood supply to their own or shifting blood supply to their own tumor cell, that will deplete the red blood cells in the general circulation. And so you should be asking yourself, why in bleeding, ulcers, anything that has a chronic blood loss associated with it, why does the patient suffer from iron deficiency anemia? And it goes right back to the depletion of iron stores. Remember, we're storing iron in the form of ferritin and hemosiderin. And so when those are depleted, then you're going to not be able to synthesize red blood cells, or what you end up with is hypochromic microcytic red blood cells. Also impaired duodenal absorption of iron, because we do absorb iron from the duodenum. And in many disorders where there are malabsorption syndromes, you're also going to expect to see iron deficiency anemia. So for example, during week 4, where we cover GI disorders, you'll see with patients with Crohn's disease, for example, they will tend to be anemic, and not so much because they're losing blood from their stool, but more so because they end up with malabsorption because of the changes that are happening to their GI tract. And any form of severe liver disease, you would expect your patients to also suffer from anemia. And primarily because of that iron storage. Remember, we said iron stores are happening in the liver. So if you end up with severe liver disease, be cirrhosis of the liver or something like that, then you know the patient will be at risk for iron deficiency anemia. So looking at the signs and symptoms of anemia, or iron deficiency anemia, we have covered a couple when we spoke of anemia as a general term. Mild anemias are often asymptomatic. The patient may not know. It's just you might have a little bit of feeling kind of tired. So you go to your family doctor, you get checked, and you're diagnosed with a mild form of iron deficiency anemia. They probably would start you on supplemental iron, or even say to you, depending on how mild it is, try to consume iron-rich foods. However, as the hemoglobin starts to drop, then your patient becomes more symptomatic, right? So we talked about before about the pale skin and mucous membranes. So mucous membranes, you're always going to check with your patients of darker skin tone. We discussed that the pallor is related to the SNS activation, and also because we know when blood gets to an area, it generates heat and also gives it that nice color, that flush pink color. As the hemoglobin also starts to drop, the patient becomes fatigued, lethargy, and cold intolerance, again going back to the production of heat and ATP production that is required with oxygen. And so if your patient doesn't have enough hemoglobin, they lack that oxygen carrying capacity, which means therefore that metabolism is kind of slowed, heat production and energy production is also slowed. Irritability, hypoxia again, degenerative changes that you're going to see, stomatitis that we talked about, and just reiterating again, stomatitis has to do with mouth, so where we have kind of inflammation, ulcerations in the mouth, and sometimes it involves the lips. With women, if you're suffering from iron deficiency anemia, can end up with menstrual irregularities starting to happen, delayed in healing, which completely makes sense going back to your patho 122. Remember, anytime we need healing, we need oxygen and nutrients to the area, because it's now when something is damaged, we need regeneration of new cells and new tissues. And that only can occur when we have oxygen, nutrients, and things like protein in the area. So if there is not enough oxygen in the area because you're anemic, you're going to see delay in healing on any wounds or anything like that. Tachycardia, heart palpitation, dyspnea, and syncope mostly are related again to the compensatory mechanism related to SNS activation that you're starting to see those signs and symptoms. So when we look at the diagnostics, a lot of it is self-explanatory. So if we're going to try to diagnose iron deficiency anemia because your patient is now symptomatic, a couple of things we look at is the hemoglobin level, obviously, and see what the patient's hemoglobin level is. We're going to look at their hematocrit, levels as well. Their mean corpuscular volume, or what stands for MCV. And MCV is really looking at the mean number of cell volume. It's measured in relation to the average volume of red blood cell corpuscle that you have. So as you can imagine, if you're measuring the concentration or the average volume of red blood cells that you have, when we have iron deficiency anemia, the synthesis of those red blood cells would be low, so therefore your volume will be low, indicating that your MCV would be low. MCH, or the mean corpuscular hemoglobin, what that looks at is your MCH is looking at the average quantity of hemoglobin that is present in a single red blood cell. And going back to the very first diagram that we did, we said iron is a significant composition of hemoglobin, right? It's heme. So if you're looking at the average mass of a hemoglobin cell, then therefore what you're expecting is the mass is going to be low if the hemoglobin is lacking iron, right? Microcytic, hypochromic. So the MCH will be low. Some people would have not so low hemoglobin, but if they have other signs of iron deficiency anemia, then your physician might run a serum ferritin level or a serum iron level, or they will look at the transferrin saturation. So iron is usually found bound to transferrin, and so if the iron levels are decreased, what they would find is your transferrin levels will start to increase because they are in significant ratio to each other. So they're looking to, so they're kind of married to each other. They want to stay bounded to each other. So the transferrin and serum iron are usually binded together. So once the levels of your iron starts to decrease, you're going to have transferrin that doesn't have iron to bind to, so those transferrin levels will start to increase.